Okay, welcome everyone. Thank you so much for joining us tonight. We truly appreciate it. My name is Julie Busby. I'm the founder of Busby Group. We are a top 1% residential real estate team in Chicago, and we are unique in that we are all about service. We actually have an in-house concierge where we are doing everything we can for the consumer, obviously anything for the real estate transaction, but beyond in your life, in your lifestyle. And that's how we started these webinars. We tend to do about one every 2 months, and we listen to the consumer and what's important to them. And, heart health is a hot topic right now, and it's Heart Health Month. So we thought, what a perfect opportunity to have this presentation tonight. And Barb, our director of luxury at Busby Group, is actually on the board at Rush Hospital here in Chicago, which is a world-renowned institution. So she put together this event. And Barb, I will let you introduce our panel.
Sure, thank you. Good evening. I'm glad you're joining us tonight and we're able to present this important programming. We've all heard that home is where the heart is, and we believe the right home can actually contribute to one's overall well-being. So tonight, from our homes to yours, let's focus on well-being and heart health in particular. It was at Rush that I was introduced to the groundbreaking work that Dr. Volgman and Sanghani are doing in the field of women's heart health. I was surprised to learn that since 1984, men and women in increasing numbers have been dying from heart disease. Let's find out why. There are over 150 of you on this call tonight, but we promise to leave time at the end for your questions. You can just submit them into the Q&A at the top right, or you can, as they said, leave a chat. And now I defer to our special guests, Dr. Annabelle Volgman and Dr. Rupa Sanghani of the Rush Heart Center for Women in their signature red. Doctors?
Thank you so much, Barb and Julie, for inviting us to this webinar. We love to take part in these educational webinars because I hope that it will help people understand how important heart disease is to their health and how you can prevent heart attacks, strokes, and premature death. We want everyone to live long, healthy lives. My father just passed away at 91 and a half years old, and he definitely lived a long, healthy life until the very end. But we are celebrating his life because he had a great long life and he left a lot of legacies. So with that, I dedicate this lecture to my parents who both died of heart disease. So I'm going to just give you some facts and then give you some epidemiology about heart disease in women and men. And then I'll turn it over to Dr. Sanghani to talk about the risk factors and all the different kinds of heart disease that women in particular have compared to men, or as opposed to men's hearts. So 1 in 3 adult women have some form of cardiovascular disease, and that includes hypertension. As you know, there are so many people with hypertension or high blood pressure, and it is so treatable, and you can prevent it, and Dr. Sanghani will go over how you can prevent it. But I'm sure you can get a lot of information about that, but we just want to emphasize how important it is to treat that high blood pressure. Please don't wait to have to go to the emergency room to get that treated, because it might be a stroke. That could be the first sign of heart disease or hypertension, and we can easily prevent that. Women and men have similar cardiovascular risk factors, but women have some female-specific risk factors, including disorders of pregnancy, and Dr. Sanghani specializes in women who are pregnant and have heart disease or develop heart disease during pregnancy. Menopause is another transition that makes us have a higher risk of heart disease. Women tend to have lower risk of atherosclerosis or plaque-building disease that causes the heart attacks and strokes. But during menopause, that's when we transition to that higher risk. So that is another particular problem that we need to pay attention to. And of course, women have a lot of breast cancer, and they can either have heart disease during their episode of breast cancer that we need to learn how to treat. And there's a field of cardiology that is specifically dedicated to treating women who have cancers and how we can prevent heart disease in those women and how we can treat them if they do develop cardiovascular disease during the treatment of breast cancer, because breast cancer treatments can cause heart disease. So we have to learn all about that. And we do have a specialist at Rush. It's called cardio-oncology. And Dr. Tochi Okwiosa is our cardio-oncologist, and she's been teaching us how to take care of these people with all kinds of cancers. As Barb said, she first learned about how high the risk is for cardiovascular disease in women. As you can see from the slide, the blue line is cardiovascular disease mortality in men. And in 1980, there were about 30,000 more men dying of heart disease than women. And this was when it was reported to us that heart disease affects men more than women. And unfortunately, what that did was we took care of the men. We paid a lot of attention to the men. We did not treat the men the same. We did not treat the women the same way as we treated men. We gave them statins. We lowered their cholesterol. We taught them how to lower their cholesterol, lower their blood pressure with a lot of medications. But until the 1980s, we were not treating women statins as much as we were treating the men. So statins came around here. We were treating women with hormone replacement therapy. And unfortunately, as you can see, there became a huge discrepancy in how many women were dying of cardiovascular disease than men. The men were treated with the life-saving drugs that statins afforded, but hormone replacement therapy in the women that were studied, that we studied during that time, we found that hormone replacement therapy given to women over the age of 60 or after 10 years after menopause was actually increasing our risk of strokes, heart attacks, and deaths. So it was the WHI study, the Women's Health Initiative, that was started by a woman, the first NIH director, created all these studies, studying all the diseases in women that really made us understand that hormone replacement therapy after a certain age was deleterious and was dangerous for women over the age 10 years after menopause. So what did we do after we found this out? Well, we stopped hormone replacement therapy, and unfortunately, it wasn't until about 10 years later that we learned that we can give hormone replacement therapy in younger women, and it does not cause the same problem. So, we're learning, and we're really trying to change the way we practice so that we are helping as many women as we can. But as a result of this discrepancy, by the year 2000, there were now 70,000 more women dying of heart disease than men. And so we really did a lot of efforts. The NIH and the AHA started their wellness campaigns about women and heart disease. We made people aware of heart disease in women. So we treated women more aggressively with statins, lowering their blood pressure, stopping the hormone replacement therapy in the appropriate women. And we also found that there's a biomarker called troponins that can detect smaller heart attacks. And it really helped women to detect the small heart attacks that we were finding in women. And of course, we started the heart centers for women in 2003. And as a result of that, I'm sorry, let me go back to this. This is supposed to, we saw this huge decline in mortality in women compared to men. So this huge decline from 2000 and 2010. We were celebrating, we were jumping up and down, and that we were able to decrease cardiovascular deaths in women by so much in just 10 years. Unfortunately, since 2010, we are seeing an increase in both men, especially men, and women dying from cardiovascular disease. And we are shaking our heads and scratching our heads and wondering what is going on. Well, we believe that unfortunately obesity and increase in hypertension, as people lived longer, now people are, as like my father and my mother, they died in their late 80s or early 90s. They developed heart disease, and of course they died of cardiovascular disease. So we feel that the advanced age that we are seeing our population live up to is causing that increased deaths in cardiovascular disease. But what we do want to prevent are the early heart attacks. Premature coronary heart attacks are so devastating to any family. So we still have to pay attention to our diseases that can cause these heart attacks and strokes. So we're going to talk to you about how we have been doing that at the Rush Heart Center for Women and at the Rush in general, because we are trying to prevent heart disease and not just treat heart disease when we see it. We are very much into preventing heart disease, and we'll talk about that tonight as well. In terms of differences in symptoms, we do see that women are more symptomatic. You can see these studies that show that angina, or the chest pain that is caused by heart disease, is much more prevalent in women. So these studies all prove that women are more symptomatic than men. So a few studies show that women are just as symptomatic as men, but there are many studies that show that women are very symptomatic when they have heart disease. So we treat all those women that have symptoms of chest pain or shortness of breath. And women, unfortunately, don't usually like to say chest pain when they're having symptoms. They like to say it's a discomfort, or they have arm pain or jaw pain. And we know that this is the case in a lot of women. They don't feel that chest pain. And so we have to really be careful in how we interpret the symptoms. So if a woman comes to me with lots of risk factors, no matter what they say they're having, if they have any pain around their chest, I will be very aggressive with that. And then what we also notice is that when women present with coronary artery disease or heart disease or plaque in their arteries, they often, you can see the women are in the gray bars compared to the men in the black bars. At any age, men have more obstructive heart disease, so they're easily treated. We put stents in these men with obstructive heart disease because there is a block in the flow of the blood in the arteries of the heart. But women tend to have smaller plaques, smaller amounts of plaque, not all, but the majority of women don't have obstructive coronary artery disease, where we see a blockage in the artery that we can easily treat with stents. So Dr. Sanghani has worked very hard to help lots of women who present at Rush with this, and she'll tell you about what we have done. Unfortunately, there's a misconception among women that breast cancer is their number one cause of deaths. That cannot be further from the truth. There are a lot of women getting breast cancer, but there's actually more women developing cardiovascular disease than breast cancer. At the age of 40 years old, the lifetime risk of women having a risk of breast cancer is 1 in 8 compared to cardiovascular disease, which is 1 in 2. So half of women at the age of 40 will develop cardiovascular disease, and only 1 in 8 will develop breast cancer. By the age of 70, that risk of breast cancer actually goes down to 1 in 15. So it's even half by almost half, from 40 years to 70 years of age. But in terms of cardiovascular disease, the risk remains high. 1 in 2 women after the age of 70 will develop cardiovascular disease. So I'm going to turn it over to Dr. Sanghani, who will talk to us about the risk factors of developing heart disease in women and men, and she'll tell us about the differences.
Thank you, Annabelle. Thank you, Annabelle, and thank you everyone for having us here today. So let's talk about risk factors. Before we get there, I'm going to do a little bit of pathology. I promise this won't be too much, but I think it's important for you all to understand what atherosclerosis is, okay? So when we talk about plaque buildup and kind of general heart disease or generic heart disease, this is the inner lining of your blood vessel called the endothelium. This disease, you get almost like little breaks in the endothelium, but you develop fat globules, lipids, into that area and the space in the blood vessel. And so actually when the heart arteries get diseased, it actually affects the wall of the artery first. You get cholesterol that deposits in here. That causes inflammation. So you get macrophages and other immune cells in there. And it starts to build up in the wall, and then eventually it starts to narrow and cause a real blockage. If it's just a narrowing, we can treat that. People come in with symptoms of chest pain and we can open up the artery. The more serious part is when the endothelium actually breaks open or ruptures open. It's what we call unstable or vulnerable plaque. And when that breaks open, the body sees it like a cut, just like it would on your hand. And it says, oh, I need to form a scab there. But in a small straw-shaped structure, that blood clot becomes a full-blown heart attack. So, of course, this is what we want to prevent. But I think it's important for you to understand a lot of our risk factors tie back to the fat and the cholesterol, the inflammation in the immune system, and then how stable this plaque is to begin with. And a lot of our newer and novel therapies really target that. So what are the risk factors that we think about in heart disease? Well, most of these, you guys are aware of a lot of these, right? On the left, we have traditional cardiac risk factors: obesity, smoking, diabetes, cholesterol, physical inactivity. I'm sure that most of you are aware of this. These are all the good common sense things we need to know. But on the right are non-traditional risk factors, and ones that we're learning have an impact in women. And so let's go through these in a little more detail. This slide actually has them in the opposite order. The traditional risk factors are on the right and emerging on the left. But we know that even the traditional risk factors are different in women than they are in men. So for example, your cholesterol profile changes dramatically with menopause. Your triglycerides go up, so does your LDL, your HDL drops. And so the protective estrogens that we had up until menopause, all of a sudden our numbers really start to crumble. Hypertension, we know that hypertension is very prevalent in women. It's what we call the silent killer because there's no symptoms usually with benign hypertension, but long term, when the arteries are stiff, it causes problems, not just in the heart, but in the brain, in the kidneys, and in other organs, but you don't generally have symptoms from it right away. Now, the treatment for that is going to be to start with a low salt diet and then medications in some people. Diabetes has a 45% higher risk of ischemic heart disease in a woman compared to a man. So diabetes makes a much bigger effect on us. We all know at this day and age that smoking is bad for us, but again, a higher risk in a woman compared to a man. And of course, obesity is a big one. Now, where you put your weight is very important. We know that people who deposit their weight centrally in their abdomen and what we call visceral fat have a higher risk later on than those who put it all over the body. Inactivity is a big risk factor. We recommend at least 70 to 90 minutes of moderate to high intensity exercise per week for your heart health. But we also want you doing strength training to maintain your muscles and your bone mass and your stability and mobility as you get older. And then, of course, there's family history. Now, that's one that we can't control. But knowing if you have a family history of heart disease at a younger age, so under the age of 50 is really what we want to know. Most of us have someone with heart disease who's older, but it's the young ones where we have what we call premature atherosclerosis that we would screen for. Now, emerging risk factors, these are ones that we're learning more about. And at a place like the Rush Heart Center for Women, we look at all of these factors very closely because it gives insight in what's to come. We know that autoimmune disorders on the top left are becoming a big risk factor for heart disease. And that goes back to the inflammation that I talked about. So in particular for women, it's women that have lupus and rheumatoid arthritis, where their whole body is literally systemically inflamed. And you add on top of that other risk factors, and they develop premature atherosclerosis at a much younger age. I have literally seen women in their 20s and 30s with these two conditions who come in and have needed not just stents, but even bypass surgery in their 20s. Inflammatory bowel disease, some of that chronic inflammation is linked to coronary disease. And then we know that for sure there are hormonal factors, pregnancy-related and menopause. I'm going to get to those on the next slide. Sleep apnea is another big one. Sleep apnea is when in the middle of the night, the soft tissues kind of collapse and you snore, have brief little periods where you're actually not breathing and you jolt yourself awake because your brain says, no oxygen, breathe. People who are snoring need to be screened for sleep apnea. Treating this, that stress of not getting good quality sleep and getting into deep REM sleep, as well as the low oxygen levels over time, can contribute to high blood pressure and arterial stiffness. We know that depression has a factor for sure in women. It's more prevalent in women, and it doubles your risk for ischemic heart disease. And then, of course, there are certain cancer treatments. Dr. Volgman mentioned this. There are certain chemotherapy agents, in particular, the class of drugs called anthracyclines, which are used classically for breast cancer, and another class that are used really for the leukemias. Both of those groups, when we see that someone has had breast cancer, to me, that's an automatic signal that they've gotten a chemotherapy agent that can be cardiotoxic directly to the heart. And so people that we want to screen and watch a little bit closer. So let's talk about, where do we get our female patients? Like, what are the different risks over your lifetime? There are vulnerable periods. Now, this doesn't mean anything is going to happen, but we know that in the early years, early menarche, so early menstruation, is actually, all of these are small little incremental risks, but they add up. So I actually do a gynecologic and pregnancy history on every woman who doesn't have known heart disease that I see in clinic. I want to know, when did you start your menstrual cycles? If you were young, 9, 10, 11, tiny little increase in risk. We know that in the reproductive years is actually the time that most women come in for their health, but they're gearing it towards what we call bikini healthcare, right? They're coming in for reproductive issues. But it's a great time if we can get access to these patients to also talk about, what are you doing? Do you have PCOS? Are you having a hard time getting pregnant? And what are you doing for that? How does pregnancy itself affect you? Have you had any problems with pregnancy? Hormone replacement therapy. Of course, menopause, we know is a huge transition, and our risk goes up above that of men really after menopause. And then, of course, that eventually leads to the age-related cardiovascular disease that we see. So let's talk about pregnancy. Actually, let's talk in the middle here on this slide. This right here depicts what's called the Life's Healthy 8. And so this is the stuff I talked about: nutrition, exercise, hypertension and blood pressure management, cholesterol, not smoking, getting enough sleep. And we've layered on top now the pregnancy related things. So we know that anyone with any what we call a hypertensive disorder of pregnancy, if you've gone into pregnancy and developed gestational hypertension, if you've had preeclampsia or frank eclampsia, any HDP puts you at greater risk of developing hypertension long term. And it's often within 10 years of presentation. So women that are pregnant in their 20s and 30s, honestly, will go on to develop hypertension in 10 years. And those 10 years after delivery are when you are the busiest. Working women these days, they're trying to take care of their kids. They are not coming in to get their routine blood pressure checks because they think, I'm healthy. But this is actually when it's most important that we be seeing them at least annually or with your primary, and understanding that we need to keep an eye on the blood pressure. Gestational diabetes similarly puts you at risk for frank diabetes earlier in life than you would normally. And both of these, the HDPs and gestational diabetes, put you at higher risk for heart disease long-term. Preterm births, placental abruption, or even having a small for gestational age baby, all of these, again, small incremental risks. But it's interesting because pregnancy really is a unique opportunity for cardiovascular risk assessment, prevention, and counseling. So I counsel anyone with any known pre-existing heart problems or risk factors for heart disease like high blood pressure, diabetes. We're seeing women get pregnant much older than they were in the past. And I'm seeing a lot of even IVF pregnancies where they're in their 40s. These are women that we want to see before you get pregnant so that we can get you on the right medicines that are safe for pregnancy, do any testing that we need to assess your risk, and make sure that we're following you for the full 9 months so that we give you and your baby the best chance to be as healthy as possible. For the women that actually do develop a problem during pregnancy, I work very closely with our maternal fetal medicine high risk group, but it's counseling. It's making sure that these women know that you need to be followed closely and you need to be seeing not a cardiologist every year, but at least your PCP and getting screening for these. After delivery in this country, you get 2 days for a vaginal delivery in the hospital and about 4 days for a C-section. And usually that you go home, and in the old days, the teaching was come back in 6 weeks, really for the visit to check your perineum and to make sure that everything is healing down there. But there's been increased awareness of what we're calling the fourth trimester. So even after delivery, there's such significant hemodynamic changes in your blood volume and everything that has actually become an incredibly vulnerable time that we're following more closely. Now, imagine a woman who's just delivered a baby, who has gone home, weeks 1 and 2, where is your head? It's completely gone, right? Your hormones are flying all over the place. You're bloated and swollen. You're recovering yourself from a major either procedure with a C-section or just delivery, and you've got a newborn and are up all night and learning how to do all this. No one is taking care of themselves in those first 2 weeks, and super vigilant in those first 2 weeks. If you have any blood pressure issues or anything where I'm worried about blood pressure going up, that you be seeing your doctor. So we know when you're pregnant, your blood volume doubles. It's essentially a 9-month long stress test on the heart. After delivery, your blood vessels clamp down. They've been nice and dilated because of the prostaglandin and the hormones and everything else coming around. And it's about day 4, the vessels start to clamp down, and yet you haven't had a chance to pee out all that fluid. And so I see the blood pressure clamp down literally between days 4 to 7. And that first month can be very variable. I actually have all of my patients that I'm worried about see me at the 4 to 7 day mark, and then again about a week later, so that we can check their blood pressure. And it has saved sending a lot of these women to the ER, not having to leave their newborn at home. And we've been able to leverage telemedicine in particular in this instance, where I can keep these women at home with their babies and say, just get me a blood pressure machine and a number, and we can do this virtually. And so really important, if you've had any of these, that you follow this, that you get screened, or if you have a family member who is pregnant and having blood pressure issues, really important. The other thing to note is the blood pressure cutoffs during pregnancy are extremely different than our standard blood pressure measurements in terms of risk. So normally we want everyone below 130 over 80, and we want them well controlled for their long-term risk. In pregnancy, a blood pressure over 140 over 90 is a high-risk condition and one I would worry about. So the cutoffs, what tip your primary or someone else may be, oh, it's just a little high. During pregnancy, there is no little high. It goes from normal to high very quickly with a very narrow margin there. Let's talk now. So we've talked about risk factors and the asymptomatic patient, hopefully most of you, and saying, what can I do to prevent heart disease? But what if you start to develop symptoms? So we know that women present differently. Can they have the typical symptoms of chest pain, shortness of breath? Of course they can, and they do. But we also see women more commonly with fatigue, just generalized fatigue. I don't know what's going on, doc, but I can't do what I normally do. And I can almost bet that every woman on this webinar today would say, I'm tired. So who isn't, right? It's hard to tease out. But what I tell my patients is if something doesn't feel right, if you can't do your normal activities and it's not because you just had a cold or something like this, if you're like, yeah, I'm just not able to keep up, I'm exhausted out of proportion to what I should be, that's when it's time to come in and get checked. The types of heart disease in women are a little different. So of course we develop generic old atherosclerosis, but even how it's different. We do get strokes, but we also get diseases like Takotsubo, which is broken heart syndrome. You've probably heard about this in the news. This is where a woman has an
So this might be a good time to think of your questions and put them in the Q&A box or the chat room while we wait to fix this technical problem.
Hi, all. It looks like we had a little bit of a technical difficulty. I do believe she's trying to log back in, and we can hopefully pick back up in just a minute. We can go ahead and, I guess, do a few questions. Is that okay, Dr. Volgman, if I start asking you a few questions?
Can you hear me?
Yes.
Perfect. Okay, good.
Okay, perfect.
Yes.
So
I hope Rupa knows that. I'm sure she does. Can I just call her?
yes, that would be great. Yes, thank you, everyone. We see the frozen screen, but we're definitely on it. So sorry about this. I think it was just an internet connection.
Yeah, it's very strange.
Hi, you've reached Rupa.
Oh no! It's almost like all of her Wi-Fi went out or something.
Did everybody's?
No, we can see you. I'm just saying. Since it went to her voicemail, I thought maybe.
Okay. I will answer. Katie asked, anything to be aware of or that can help heart health during pregnancy or while breastfeeding? Probably the best thing you can do is to see your OB-GYN before you get pregnant, because you should have your blood pressure checked, and you should be examined to make sure that there's no heart murmurs or any history of heart disease that you should be aware of before you get pregnant. So that's the best thing. While you are pregnant and while you're breastfeeding, you should have your blood pressure checked. And we use the cutoff of 140/90 officially as high blood pressure in pregnancy. But honestly, we want everybody's blood pressure to be less than 130/80. That's really the safest way to make sure that you don't have a risky pregnancy. I hope that answers that question.
Great.
So Barb asked, what ages are you seeing an increase in heart disease in women? So for women who have no familiar heart disease, no elevated risk factors such as diabetes or hypertension or high cholesterol, women in general will lose that protective effect of the being a woman compared to men having heart disease early. So men, we start really screening them at the age of 40. And women, we really start screening heavily at the age of 50 because that's when they start menopause. So it's that transition during menopause that increases heart disease in women who have no risk factors. But for women with diabetes, they are at high risk from the beginning. Welcome, Rupa.
Sorry, I don't know what happened. My internet completely went down. I'm now streaming.
It wasn't just you. So hopefully, I don't know if we lost people, but
it wasn't just me. Okay, I was like, what happened?
I know. I was like, oh my God, did I do something?
No, we still have, it looks like most everyone was able to stay in. So if you want to start where you were, we answered 2 questions while you were gone, and then you can get back into it, and then we'll answer the rest of the questions right at the end.
Absolutely. Now, where did you guys all hear from? Was it symptoms?
The next slide. I think keep going to the next slide.
Okay, let's see here. Next slide is right here.
Yes, I believe that's where we were.
Okay, perfect. Back in orders. Heart disease, even in women here, develops differently. So when we think about atherosclerosis, in men, it's a nice open straw and it gets pinched. And you can see that here. There's a tight little focal stenosis, and we can go in and put a stent in and open up that artery. When women come in with heart disease, the plaque builds up more diffusely all the way around the vessel, and you get more generalized narrowing. Now, when we do an angiogram, we're injecting dye into the heart arteries, and what we're looking at is the middle part of this, not the wall of the artery. And so women will often come in, the interventionalist sees the coronary arteries, and they seem a little smaller than normal, but there's no blockage. There's nothing that's tight or focally narrowed. And so they say, oh, well, you don't have anything. Now we're getting much better at this. Now the interventionalists know that they need to look at the wall of the artery, and we can actually do intravascular ultrasound with a small wire that they can look and see if there's plaque there. But there's unfortunately still many women that come in with chest pain and symptoms of angina, and they get their angiogram and they're told, oh, you don't have heart disease. And it's honestly a misnomer that we now know that it just manifests differently in women. Now, that's not just where it manifests. So when we do an angiogram, this is actually a cardiac angiogram. On the left, we have a catheter right here, and we're injecting dye into the 3 main arteries that supply blood flow to the heart. And that's what we're looking at. We see, okay, yeah, these look fine. This is a little narrowed down here. It's a little lumpy bumpy, but we don't see anything discretely blocked. What the problem is this is what we focused on for years, is coronary artery disease. And it really means the epicardial coronary arteries, or the arteries that actually sit on the heart. 2/3 of the coronary circulation, though, is under the surface. So from these 3 main arteries, there's all these tiny branches right here on the right that actually dive into the tissue, into the muscle, and supply the heart circulation and blood flow. That's 2/3 of it. It's what we call the microvasculature. And what we've learned in recent years is that the microvasculature plays a much bigger role in women in particular. Now, again, it's a role in everyone, but we know that people with kidney disease, diabetes, this is where it affects a lot of the heart and not just in the blood vessels. And both of these are treated with medicines. This can be treated with stents. This cannot. This is prevention and some medications after we've gotten to this disease, but it's fairly irreversible otherwise. Women can come in with microvascular angina as well as typical heart disease angina. And that microvascular, those small blood vessels, can cause problems in blood flow either through abnormalities in the structure of the artery. It could be plaque buildup. It could be other things that we know that affect the vessels, or it could be an abnormality in the function of the arteries. The arteries are supposed to dilate and constrict naturally based on hormonal regulation in your body. And if that gets impaired, or if they get what's called spasm, all of that can also cause angina. So how does heart disease manifest in terms of cardiovascular disease? When we say cardiovascular disease, that includes coronary heart disease, heart attacks, MIs, angina, heart failure, cerebral vascular disease, so blood vessel issues going up to your brain, which can cause a stroke or a TIA, peripheral arterial disease, which is vessels in your leg or your abdomen with your large aorta. To me, if you have atherosclerosis in any artery of your body, it's the same organ system. It's vascular disease. The treatment is the same. It's aspirin, aggressive blood pressure, aggressive cholesterol. And if you have it here, why wouldn't you develop it here at some point in your life? And so really important that we assess and kind of screen for all of that. What can you do to protect yourself? Well, first and foremost is coming to seminars like this, knowing what your risk factors are, knowing what your numbers are. That being said, I will say that we used to go to numbers that were, we want your LDL under this number. Those were based on population-based numbers. We've really moved into an era of precision and personalized medicine. And so although I will use some of those numbers, we're really starting to look at patients as an individual and where should your targets go, not just based on what's normal for other people. So I have patients whose LDL is 90 when they come in and they're like, well, my LDL is normal. I've always been told it's fine. And I say, yeah, but you've got atherosclerosis despite what's a quote normal number compared to other people. It's too high for you. For you as an individual, you're developing plaque at an LDL of 90. And so what we know is driving that down is what's going to lower your risk. So knowing your numbers are important, but know that even how we've addressed those numbers has changed. Advocate for yourself. Women are underappreciated for heart disease. If you feel like something is wrong, you are having symptoms and you're like, this is not right. Speak up to your physicians. If they're not listening, go to someone else. And God forbid, if you have to go to the ER, advocate, speak up, ask for an EKG. Tell them this is chest pain, not heartburn, not anything else, but say, this is what I'm feeling. I am worried about heart disease. I have risk factors. Ask for an EKG. Of course, if we can keep you healthy to begin with, that's the most important thing. And if you are at all anticipating pregnancy and you know that there's stuff that you need to be aware of or that you might be at risk for, being seen before you get pregnant is really important. Now, there is one other thing that you can do for people that really want to be aggressive and kind of know a little bit more about their heart. Again, we talk about the artery getting narrowed. If we've waited till we're this small, we are way behind the boat. So one thing that we can do, again, going back to that pathogenesis slide, and we know that there's cholesterol and inflammation, and over time, what we call soft plaque or that cholesterol plaque hardens. The body actually deposits calcium there and that hardens. It actually stabilizes plaque, but that's something that we can image before it even gets narrowed and causes symptoms. So these days, a lot of you may have heard of this. There is something called a calcium score. It's a CAT scan or a mini CAT scan that we do. There's no contrast dye used. It's about 3 chest x-rays worth of radiation. And what we're looking there is there calcium in the heart arteries? And if you have calcium, it means you have early heart disease. And that has allowed us to really get to people much earlier than before. Maybe I actually recommend this for patients around 50, or unless they have a strong family history of early onset stuff. Around the perimenopause transition is a perfect time to start. But knowing then if you have calcium can make the difference between me now adding a cholesterol medicine, the statins, and an aspirin to your regimen. Unfortunately, these calcium scores are not covered by insurance anywhere in the country, which most of us think is crazy, but it is what it is. They are about $100 at most places. Rush offers them for $49, so they are not cost prohibitive. They don't need to be done every year. I recommend them once every couple of years. Once we have diagnosed you with heart disease and you are on a statin, these aren't helpful anymore. So this is really to diagnose what we call a cult or subclinical atherosclerosis that we don't even know is there because there's no symptoms. So what are the facts? All women are at risk. Heart disease rates rise in women after menopause. There are definitely ethnic groups that are higher risk, African Americans in particular. And unfortunately, women are often misdiagnosed and undertreated, and they themselves don't know they're at risk, and healthcare professionals are not doing as good a job as we should. So the goal of a day like today is to empower you to be aware and to understand and how you can take care of yourself and prevent heart disease. Annabelle, Dr. Volgman, started the Rush Heart Center for Women over 20 years ago, and she's literally been a leader and a founder of the Go Red for Women movement in this country. This is an article that we published many years back on the heart centers for women, and she has worked vigilantly with the American College of Cardiology and the American Heart Association for many years now on how to develop these dedicated centers that really appreciate that heart disease in women is different. Just this month, the ACC, with Annabelle's guidance, put together a whole toolkit on how to develop a heart center for women. So we are hoping that these will come up to more hospitals and more places, but we have a very well-established team. Dr. Volgman, again, is the founder, and I took over as the director last year, but the two of us work very, very closely together, and we have a fantastic group of docs, both at main campus, Oak Brook, and at Oak Park, and our South Loop office. I'll leave you with heart disease is the #1 killer of women. It affects every age group, and it's preventable. Lastly, Blue said on women and wellness, women take care of so many things. We take our responsibility of being wives, being daughters, being members of the community, but not frequently and not seriously enough do we take our own wellness to heart. So thank you for being here today and taking your own wellness to heart.
Well done. Thank you so much. That was very impactful. Thank you. So we do have questions. If we do have about 9 more minutes, so I'll run through some questions here. It looks like, what ages are you seeing an increase in heart disease in women?
And we're seeing it in all groups, I would say. I mean, for sure, it affects more women postmenopausally. It is still, for the generic part, an older age or disease. But we see heart disease in women in all ages. So even the younger women, 20s and 30s, are not immune. Now, those are the women who have lupus and RA or something else is off, is different. But we see it in every age group.
Makes sense. Another question, does birth control have anything to do with an increased risk of heart disease or stroke?
Yes, in particular with stroke. So we know that estrogens can increase your risk of stroke, which is generally why the GYNs won't recommend that you be on estrogens past 40-ish, or at least birth control pills, especially if you're smoking in addition. So if you're not smoking, they might continue it, but it increases your risk of blood clots in particular, just any blood clot, which can occur in the brain. It can be DVTs. in terms of heart disease, straight up birth controls, no, should not be a problem.
We do sometimes see high blood pressure in some women who are taking birth control pills. So we have to watch their blood pressure.
So this question kind of goes along with another one that's down below I saw earlier that said, what about like hormone replacement therapy? Is that also not recommended, or is it recommended?
You want me to take that one? So HRT has been very controversial over the years. So the Women's Health Initiative many years ago looked at this and said, it's bad. We're seeing higher rates of heart disease, no hormone replacement therapy. When you actually look at the trial, they used it in the wrong group of women. They used it in women that were 60 to 65 plus. And that's why they saw bad outcomes. And so there was a long time that we all said, HRT is bad, don't do it. We've really changed our mind on that. My rule for this is HRT in small amounts. When you need it during that perimenopausal transition, keep it to the lowest doses needed. But in a short time period, a few years to get you through perimenopause is fine. We've not found that it causes an increase. And, for years, we have just accepted that menopause is what it is and suck it up. You're going to deal with hot flashes and the weight gain and the brain fog. And the reality is it doesn't have to be like that. I think it's okay to take small amounts of it under the guidance of your gynecologist to take the edge off and to get you functional. I mean, if you are not sleeping well and having severe insomnia from this and having headaches and feeling awful, how are you going to exercise? You're struggling to get through your day. All of it feeds together. You've got to make sure that your hormones are in balance. And we also know that for women, cortisol plays a big factor. And so those stress hormones make a big difference as well. And making sure that you're overall healthy includes balancing your hormones.
I just want to say that the literature is, there's a lot of literature about this because gynecologists like to give hormone replacement therapy because they are often bombarded with women with menopausal symptoms, and they want to help them, but they don't want to increase the risk of heart disease. We now say that you can take those hormone replacement therapy as long as you're within 10 years of your menopause. And also, you should not do it just to decrease your risk of heart disease. There's no data that it really is beneficial to decrease heart disease. It's beneficial for your quality of life to treat the menopausal symptoms. So please don't think that taking hormone replacement therapy will prevent heart disease and strokes.
What if you've had a hysterectomy? Does that protect you at all from the hormonal fluctuations and the risk? No?
Anatomically, the hysterectomy without taking away the ovaries will not do anything. It has no impact because it's not where the hormones come from. The ovaries are what produces the hormones that estrogen and progesterone, all those different hormones that women have such complicated endocrine system. Men are simple. They have increase in testosterone in puberty. They have decreased from then after a certain age. But women, it changes all throughout our lives. And so it's the ovaries that are important. If they take your ovaries out before menopause, that you are usually put on a small dose of hormone replacement therapy, but that's a replacement therapy, not again to improve quality of life, not to prevent heart disease. I hope that answers your question.
Yes. I'm going to scroll down to a few others. I've heard that women should potentially have their LPA tested and that it isn't always part of a regular panel. Is that recommended?
Yeah, I'll take this question because I've been studying women with premature heart disease. When we started treating women, 21 years ago, I've been taking care of women actually for 35 years, but we started the Heart Center for Women, and I started to see a lot of women with early heart attacks. And often they were mistreated by telling them that they didn't really have a heart attack. They didn't have any risk factors. So why should they have had a heart attack? And these women clearly had heart attacks. They had a positive troponins. They had heart disease, and they were being told that, we don't know, maybe there's something wrong with your troponins. It was really infuriating to hear how these women were being treated 21 years ago. Hopefully that's not happening as much anymore. But what I found is that if I just look at the risk factors in some women, they have no increased risk if you just look at the traditional risk factors. What I found was that the lipoprotein A, which is a marker of familial heart disease, premature heart disease, it's very similar to L-cholesterol. It just has a little protein attached to it that makes it more atherogenic. So it causes more plaques earlier on. So these young women with family history of heart disease were presenting with heart attacks at a much younger age, and and they were not being treated appropriately.
So
the other risk factors that we should be aware of besides the lipoprotein A is what Dr. Sanghani talked about: pregnancy, the adverse pregnancy conditions such as preeclampsia, gestational diabetes, and hypertension during pregnancy. There's a question also about diabetes. I just want to make sure that people know either type of diabetes is a major risk factor for women. Type 1 is even worse because they've had it usually for a much longer time than the type 2 diabetes, which is usually more adult onset, although you can get type 1 diabetes at any age.
Someone also asked, will insurance pay for a lot of these tests?
So Rupa. So the calcium score, as we said, unfortunately is not covered by insurance anywhere in the country, but it is, again, mostly under $100 at most places. We have the calcium, we have just a calcium score for $49. We also offer a bundle, which includes a AAA screen and abdominal ultrasound, as well as lower extremity screening studies, and that's $99. Anything else, though, is generally covered if you have symptoms and if your doctor documents the indication properly. So we know kind of what to write. That doesn't mean it always gets approved, but in general, I am our director of nuclear cardiology and stress testing. I love these studies, and I'm a big believer in prevention. But in general, testing is best when someone actually has symptoms. We do a lot of, we do some of this screening stuff, but with a really good history, looking at all the risk factors, with a really good story of how active are you, what are you doing, I can kind of know what needs to be done in general. But when someone comes in with symptoms is when it's like, okay, now it's time to really start to dig deeper. And in general, insurance will cover those.
Speaking of symptoms, someone asks, they've been told that severe heartburn can indicate a heart attack. How can you tell the difference?
So it can. I mean, heartburn is anything in this area, right? So your esophagus is right here, and they come in with this burning, horrible pain that comes across your chest. So heartburn absolutely can mimic coronary disease. I think what's important to know when you have heartburn is think through, like, did this start right after you ate? Did you have a heavy, fatty meal? Does it seem to be related to food? Or does it seem to be related to exertion? And when you walk around and you exercise your body and increase the demands of your heart, now you're getting it. Again, if it's new onset and severe and you're not sure, it's always better to just come to the emergency room. But if it's short episodes and small and you're like, oh, this is kind of getting worse, those are the things that we would ask you to tease out. Is this heartburn or not? And if you're not sure, come see us and we will help decide and what needs to be done for more testing.
Can I just pop one question in here? Would you, if you felt that way, would you take a baby aspirin before you go in? I mean, what if you can't get in? Do you take a baby aspirin as a preventative measure?
So if you really think you're having a heart problem, yes. But, aspirin has had a lot of controversy and a lot of new data in the last few years. So if you have known heart disease, if we see that you have plaque or atherosclerosis, aspirin is absolutely indicated. But the people who are taking an aspirin because they think it's going to prevent heart disease, it doesn't prevent, and the bleeding risks actually outweigh the benefits there. So I think there's been a lot of confusion with some of the newer data on when to take an aspirin and when not. But if you're having an acute episode and you're really worried it's your heart, in general, yes, probably taking an aspirin is fine, but that's a complicated answer because it also depends on your bleeding risks and other things going on.
Okay.
Is there a specific age that we should be seeing a cardiologist, or do you keep seeing your primary care and they refer when it's time?
Take that one, Annabelle.
Sure. So if you have any risk factors, you can certainly see us. We do a lot of preventive cardiology in the Rush Heart Center for Women. So we would never turn down anybody who wants to see us to prevent heart attacks. So there's no shame. A lot of women come to me. It's like, I feel like I'm taking too much of your time. I have nothing. Mm-hmm. It's like, well, you're taking care of yourself, and we make them feel that it is not a waste of our time. We want to prevent heart disease. So anyone is welcome to come see us. And then if we find that they have no symptoms and no risk factors, we will generally tell them, that they don't have to continue to follow us. But a lot of people do come to us with some reason or another. But your internist should also be doing these prevention steps, like the coronary artery calcium score. I think any man after the age of 40 or any woman after the age of 50 should get a calcium score, because there are so many hidden risk factors that we really don't know about.
Someone asks about drinking alcohol. How does that affect stroke or heart disease?
It's a very complicated answer, because unfortunately in the past, alcohol was thought of as good for the heart, and there's a lot of controversy about that now. I treat a lot of patients with atrial fibrillation, and so I never liked my patients to drink alcohol to be protective of their hearts, because I think that too many people will drink too much, and then their risk of atrial fibrillation goes up, especially people who have risk factors for atrial fibrillation, like tall people or people who have high blood pressure or diabetes. They really should minimize their alcohol intake, if not curtail it. Once you have atrial fibrillation, I really strongly recommend that they stop drinking alcohol, because it is a big risk factor for getting atrial fibrillation. And atrial fibrillation will give you 5 times the risk of stroke than somebody who does not have atrial fibrillation. So I think you should not drink alcohol to prevent heart disease.
We are reaching we're a little past our time, so I'm going to end with one last question. And if anyone missed a question or want to submit more questions, feel free to reach out. We will make sure there's a follow-up email, one with the video, and 2, you can ask questions to the doctors. I think this is a good one to end on. What are the smallest changes we can make in our daily routines to get the biggest impact on our heart health?
I'll take that. It's the common sense, day-to-day stuff, the little things that make a big difference, right? So I think it's what we all know, and that it all boils down to diet and lifestyle, and it really does make a difference. So I would say cut out or limit alcohol. Don't drink your calories, because they don't help you in any way. So omitting sodas, sticking to black coffee when you can, water, tea. Eating as healthy as you can. And it doesn't have to be complicated. There's so much with fad diets out there right now. My general rule is eat food, real food, stuff that you learned about in kindergarten that grows in nature. Make it at home, not processed. Limiting your saturated fats, which is animal products, does help from a heart standpoint. Doesn't mean you have to go vegan. But eating more, I'm so sorry, since I'm using the Wi-Fi on this, it's not working properly. the eating, limiting your saturated fats is important, not smoking, and then being as active as you can. And even exercise doesn't have to be fancy. It does not have to be an hour block of time, which I think for all of us is daunting. I don't have an hour to get dressed and go to the gym. It doesn't have to be that. I mean, that is absolutely wonderful and recommended. But if you have a busy day, walk up a few steps in the house, do some squats right where you are. Whatever little bit that you can move makes a difference.
That's great. It's a good reminder. Well, thank you everyone for tuning in. We truly appreciate you spending the evening with us. And doctors, we are so thankful for so much of the incredible information you shared. Thank you. Thank you. I think we will be making this an annual event. So I just want to say we are so thankful for this opportunity.
Thank you
very much.
Thank
Have
you
a good
for having
evening,
us.
everyone.
All right.
Bye.
Bye-bye. Bye, everyone.